we've come now to the final portion, the final third of the presentation on neuroaudiology diagnosis. Since I prepared the second presentation, my voice has deteriorated. I do have a bit of a virus or cold from traveling, so I hope I can make it through this, and I apologize for the quality of my voice. Uh, at the end of the last section, I introduced the ASSR, and that's where we'll pick up. Of course, we need to have frequency-specific information to manage children with hearing aids or to determine that they need a cochlear implant. And again, you've seen this slide. We need information, on an octave region around 500 hertz, 1,000 hertz, and maybe 2 or 4,000 hertz. I usually try to get information on 4,000 hertz, 1,000 hertz, and 500 hertz, plus the click. The click ABR, of course, is giving us information on that region between 2 and 4,000 hertz. Now we can get that information, of course, from tone bursts, but the problem with tone bursts, one minor problem is that the output is limited because it's such a transient or brief stimulus. So most ABR systems do not allow us to get to intensity levels above around 90 dB, maybe 95 dB NHL with the tone stimuli, the very brief tone burst stimuli. And remember, the duration's only about 4 to 5 milliseconds. But if we could use a pure tone stimulus, we could then have more energy in our stimulus, and we could reach intensity levels of 120 or 130 dB if necessary. And that is the stimulus that is used for ASSR. Now, there really actually are two strategies for using stimuli for ASSR. The traditional ASSR stimulus is a pure tone, as shown here. This is a 2,000 hertz pure tone, modulated or changed in amplitude at a rate of 100%. 100 per second, 100 hertz. That's a traditional stimulus, a pure tone that's modulated in amplitude and sometimes slightly, about 10%, modulated in frequency. There are some devices that actually present stimuli that are essentially tone bursts at very, very fast rates, which is another way to get more energy into the stimulus in any unit of time, such as a millisecond or second. So this is the traditional stimulus for ASSR, pure tone changed in amplitude. Now that again gives us more energy in the stimulus, which allows us to estimate hearing at levels, or hearing loss at levels that we can't reach with tone burst. So one big advantage of ASSR in pediatric evaluation, pediatric neuroaudiology, is to estimate thresholds in the 80 dB range and above. So it's possible to estimate severe to profound hearing loss thresholds, which we can't do with ABR, and even to show that there is no response to sound even at very high levels such as 120 or 125 dB. Now, that's very useful because if we know that there's absolutely no response to sound at any intensity level, even 120 or 130 dB in an infant, we know that child's only hope for management with some type of device that will allow them to communicate verbally, orally, would be a cochlear implant. And of course, we always give the parents the decision. They always have the ultimate decision on how their child should be managed, but we always present a cochlear implant as an option. And of course, many parents, most parents, certainly hearing parents, will immediately accept that option. We can get to that point within really a day or two after the child's born if we have ASSR proving that there's absolutely no response at all. Now, of course, we'll reevaluate them over the course of 3 months to 6 months to verify that there is no response to sound before making the final decision to go ahead with a cochlear implant. So ultimately, Our goal, of course, as I mentioned already, is to estimate thresholds for the child so that we can then know how much amplification the child needs so that the speech spectrum is louder, made louder, more intense, and even the faintest, softest regions of the speech spectrum are amplified adequately using a prescriptive hearing aid fitting technique to make sure that all sounds, all speech is audible for the child. And with the ASSR, we can do that at pretty much any level, from very faint or mild hearing losses all the way through to profound hearing losses. Now, of course, sometimes the child's hearing loss is so great that they will not benefit from amplification. But again, ASSR can help us reach that conclusion much quicker. Well, is ASSR required in infants? And according to the Joint Committee on Infant Hearing, the JCIH, it is not required. The ASSR is a supplementary procedure, and I would agree with that. It's not needed in every child. Like electrocochleography, it's used selectively, but when it's needed, it provides very valuable information. Now, in recent years, the traditional ASSR with pure tones has been um, restudied using chirp type stimuli. We've already talked about chirp stimuli, which are a much more effective way of activating the cochlea. And the results of this research show incredibly short test times. That is, because the response is bigger, it takes less time to see it. The ASSR is detected rather quickly. These are just few of the many articles on that topic. I'm going to highlight another article, a more recent one, to illustrate what I'm talking about. This is an article that was published by some very well-known audiologists. Yvonne Sinninger's been around for many, many years. She's semi-retired, but still involved in research and writing. Lisa Hunter, I think you know her name, very well known in the area of audiology, particularly admittance measurements, wideband reflectance. Deborah Hayes actually was one of the co-authors of the cross-check principle article, but she's published many other papers, very, very well known in audiology. Pat Rausch is also done a lot of work in auditory neuropathy spectrum disorder at the University of North Carolina. And then there was a final author, Kristen Uhler. And this is a paper that just was published in 2018 in Ear and Hearing, and I recommend it to you. It was using a piece of equipment, a device called the Intracoustics Eclipse system, which does have already chirp stimuli for ASSR. In the interest of time, I've actually narrowed down the figures that I usually talk about from this study to one figure on the ASSR and ABR. And you can see here when the ABR is the open circle, the ASSR are the closed or blackened triangles, and you can see that the ASSR is far quicker. When a baby is asleep, quiet, or even fussy, or under anesthesia, the test time, and this is using all the tone bursts that we talked about, or all the frequencies we talked about, is only 20 minutes. Quite amazing. And when we look at the ABR, we're looking at still, I mean, it's still good with chirp. We're up around 30 minutes for fussy or quiet children, but clearly the ASSR seems to be providing a speed advantage here. Now, that didn't used to be the case for traditional pure tone stimuli for ASSR that were modulated in amplitude, but for the chirp stimuli, the ASSR does appear to be much quicker. Now, I've been emphasizing the cross-check principle and the concept of not just relying on ABR or just relying on ASSR. That'd be a huge mistake, and it would not be consistent with current standard of care. We must use the test battery. We must use different independent measures of auditory function. And this point, the value of using different procedures is illustrated by this same study by Yvonne Sinninger and colleagues. What they found was that if you take, and I've also seen this in all of the patients that I've seen over the years, if you take all the children who are a refer outcome for newborn hearing screening. In other words, they fail a newborn hearing screening. Now they're coming in for an ABR, a diagnostic ABR, and a diagnostic assessment in general. Only 50% of them have hearing loss. So if you perform wideband tympanometry right away, you'll rule out any child with middle ear problems. And as you can see, most of the children that they studied had normal wideband tympanometry, that tall bar. Okay, so now you know the middle ear is normal. So then you say, well, what were their OAEs? And if you look at that bar over in the far right of this figure, you'll see that most of the children had perfectly normal DPOAEs for 6 different data points. So that tells you before you even start the ABR or ASSR that they're likely to have normal hearing. Now, tympanometry is not a test of hearing, so a normal tympanogram doesn't mean they have normal hearing. They could have no hearing. And OAEs are not a test of hearing. The fact that they have normal DPOEs doesn't mean they have a normal audiogram. They could have auditory neuropathy. They could have inner hair cell involvement. But the likelihood, the odds are great that this child has got normal hearing, which allows you to come in with a ASSR using chirp stimuli at perhaps a level of 20 or 25 dB and immediately get down to threshold in a short period of time. So if I suspect a child has normal hearing sensitivity, perhaps they have language delay but no other risk factors for a hearing loss, then I'm going to modify my approach with that patient because I'm going to assume that they have normal hearing until I prove they don't. And most of the time I'll be right that they do have normal hearing, and it takes far less time to record an ABR, ASSR, and that child because you start at low levels and you pretty much jump to each new stimulus. You go to a very low level just to confirm that their hearing thresholds are normal. Okay, so now we've talked about ABR, we've talked about tone burst, we've talked about bone conduction ABR, we've talked about chirp stimuli, and now we've just completed a review of ASSR. How do we get the child to sleep? You remember I've focused much of this lecture on what our ultimate goal in performing an ABR. Obtaining the biggest signal to noise ratio we can. The signal is the ABR. The noise is all the electrical activity that is not an ABR. Any other electrical activity, we're not talking about acoustic noise in decibels, we're talking about electrical noise. Anything that's not an ABR is noise, and of course we want to record just the ABR. Well, if we can get the noise very, very low, our assessment usually goes pretty smoothly. In fact, I easily can perform an ABR in 20 to 30 minutes, sometimes less, if the child's very quiet. So how do we get them quiet? Well, if you're not in a medical environment, or even if you are in a medical environment, the first strategy, I think, should always be natural sleep. Natural sleep is the safest, and it's the least expensive. It requires the least medical support, and so we should always try it. Natural sleep very often gets a child to the point where they can sleep not for hours, maybe not even for 1 hour, but certainly for 30 minutes, 20 to 30 minutes. And that's all we need, that amount of time to complete our ABR if we use the techniques I've been discussing. Another option, illustrated in the upper right hand corner here, is sedation. Sedation with a conscious sedative, which means you can wake the child up at any time. The sedative only helps them sleep. And you need medical support for that, as, for example, a nurse, and you need monitoring. You need to monitor blood pressure, you need to monitor heart rate, you need to monitor oxygen saturation. All of that is illustrated in that top right figure. The third option, which sometimes we need to get to, is actually performing the ABR with the child anesthetized, very lightly anesthetized in the operating room. So we're going to quickly review these different options. Wiggly children, restless children, fussy children produce muscle artifact. The muscle artifact is hundreds of times bigger than the ABR we're trying to detect. And unfortunately, the muscle artifact, or EMG, illustrated in this figure with the long, long light blue arrow, EMG has a frequency composition, or a spectrum, right in the middle of the ABR spectrum. So we can't filter out muscle artifact in most cases. Sometimes muscle artifacts very low frequency, sometimes it's very high, but when a child is restless, there's just no way you can filter that artifact out. So there is some artifact we can filter out, and some some electrical signals we definitely can filter out, but not usually muscle artifact generated by a wiggly patient, a restless child. So how do we deprive the child? It's very straightforward, but it requires good communication with the caregiver and the parent. You want to tell them, and this should be in writing, and it should be done the night before the assessment, to keep their child up as late as possible, at least till 9 or 10 at night, at least a couple hours past their normal bedtime. Keep the child up. Don't let them fall asleep when they want to fall asleep. I schedule sedated ABRs, sleep deprived ABRs, natural sleep ABRs for 8 in the morning, 8 or 8:30, whenever the clinic opens. The parent's going to have to get their child up early to get to the clinic, and you want to have, or whoever takes the child to the clinic, it doesn't have to be the parents. Two people should do that. One to um, drive the car if they're driving, or if they're taking public transportation. One to kind of take care of the tickets and everything, and then the other person, their job is to keep the child awake. Constantly stimulate the child. Don't let them fall asleep. As soon as the child starts to get drowsy, stimulate them uh, with lights, with activity, don't with movement. Don't let them fall asleep. The moment they show up at the clinic at 8 or 8:30 in the morning, I immediately am standing in the waiting room. I scrub their skin on the forehead for the non-inverting and ground electrode. I scrub their earlobes immediately, and I take them right back to the ABR room. I put the disposable ear electrodes onto their skin, and then I let them fall asleep. We turn the lights out. We tell the parents to feed them and to do whatever they normally would do. If they're sleeping, if they're already in a car seat, such as this little child, and they're already sleeping when I finish scrubbing, then I just leave them right where they are. This is a perfect environment, or for perfect setting for an ABR. And you should be able to get about half an hour to 45 minutes solid, deep sleep, and that's all you need to perform the ABR. Now, if that doesn't work, there is another very safe alternative. It's a sleep aid called melatonin. I take melatonin all the time when I travel. I never have jet lag. I just take it when I should be going to bed. I don't take it any other time. It's activated by dark. It's an antioxidant. It's quite healthy for you. And we all have it in our body. But the melatonin supplements that you give the child or you take yourself just add to the melatonin. And it basically tells you that, or tells your body it's time to go to sleep. Melatonin resets your biological clock, your circadian rhythm. And there's several studies showing that just the use of melatonin, which is totally safe, you can't overdose on it, doesn't make you drowsy, it's not going to affect the brain in any negative way, that this really does work. So here's the first study, 2007, more than 10 years ago, from Germany. Children of different age, they gave different doses. The pharmacy actually ground up the melatonin, which usually comes in a pill, but you can get it in liquid form also. In this case, this study, the melatonin was ground up and dissolved in water. For young children, I would use just a dropper and put some of it into their mouth that way. For older children, this would work out very well. And so they drink water, or they could drink juice or whatever their favorite drink is. And then give the child about 15 minutes to 30 minutes to fall asleep. And as soon as the lights have to be out totally, it has to be totally black, very, very dark. And then the children fall asleep. And in this test, in this case, this study, the authors found that more than 80% of the children fell asleep long enough to perform a complete, adequate ABR. Now, there are two other studies of melatonin, more recent, 2016, and one that's even more recent than that. And here they are. I've used this technique, and it does work. The only thing I would recommend is that you get the approval from the pediatrician to do this, or actually have them be involved in determining the dose of the melatonin. Again, conscious sedation is another option. It's quite safe. Very few, if any, contraindications to it. Nothing's going to happen to the child if you follow the proper protocol, but you do need nursing support. You need a doctor in the area. You need a crash cart, a way to achieve an airway if there's a problem, a way to resuscitate the patient, a way to suction out their windpipe if need be. So this is not something you would do in a clinic without medical support. There are advantages to using sedation in a clinic, quite a few advantages. It's not that expensive. It's quite easy to schedule a patient if you're in a medical clinic. We always used a nurse and we always had a pediatric otolaryngologist nearby. And another good big advantage is you have all your audiologic equipment there, your tympanometer, your OEE device, everything else. But there are disadvantages. Not every child falls asleep. Sometimes it takes a long time and you can't reverse chloral hydrate. You can't give another drug to make the effects go away. So the only way you can um, get the child to wake up is to wait. If it's like having too much to drink, you can't just take another. You can't take a cup of coffee and suddenly you're totally sober again. And the same thing with chloral hydrate. It is just like that. It depresses the central nervous system just like alcohol does. And in the United States, it's fallen out of favor. It's not used. It hasn't been used for quite a while because of that. It takes too long. There's a big emphasis on productivity in the United States, and we just can't wait around for a few hours for a child to wake up before going on to the next patient. So it's not available in the United States. There are some studies recently, this is 2015, 16, 17, of alternatives to chloral hydrate that are available in the United States. And these studies, this is one of them published in a peer-reviewed journal, are very encouraging. Basically, these studies are showing that these alternatives to chloral hydrate are conscious sedatives that are just as good, give you just the same effect. Now, the other option again is the operating room. I've done hundreds and hundreds of ORs, ABRs on just kids who need hearing tests. Here I am sitting at an old Nicolay piece of equipment with a student looking over my shoulder on the left, and the child is laying there on the table. The anesthesiologist is just out of view at the head of the child. I like doing ABRs in the OR because I know the child's going to fall asleep, and I know I can be very quick because they're very quiet. There's no movement whatsoever, but there are many, many disadvantages of doing this. Here are just some of the disadvantages. In the United States, it costs well over $4,000 to put a child into the operating theater and to have them sedated or anesthetized because there's so many people involved, and the space cost. You have to They have to pay for the space, they have to pay for the drug, etc. Of course, it's not easy to schedule. You need a physician who's willing to help you secure the OR team, and of course there are some risks. And children who are struggling already, who might have cognitive problems, developmental problems, may very well be worse off after the anesthesia. So this is only used as a last resort when we're quite sure there's a hearing loss, and we need to do this to get valid results to begin managing the patient promptly. Okay, we're going to move on now to the cortical responses, and I'm very cognizant of the time. We're now about 22 minutes into this, so I'm going to try to wrap this up in 40 minutes, which should put us at maybe a little more than 3 hours for the total lectures. The first cortical response I'm going to talk about is the middle latency, and I'm going to go through the historical overview and then quickly discuss a protocol. All of these cortical responses coming from above the brainstem, of course. The middle latency actually involves the thalamus and the cortex, whereas the later responses are pure cortical. I say the time has come in the title to this slide, and I really truly believe that. There's no reason why audiologists can't routinely be using cortical evoked responses when they need to. Not in every child or every patient, but the technology is available. They're not really more difficult to record than the ABR. The only challenge is the child or the adult can't be sleeping. So you have to somehow get a child to be quiet, but not asleep. If a child or anyone is sleeping or in and out of sleep, that will affect the responses. But very often in children, it's possible to distract them and keep them occupied with a video or some type of cartoon or something they like to watch to keep them awake and alert without moving around. Middle latency was first described over 60 or exactly 60 years ago in 1958 by this fellow Dan Geisler, who was a basic scientist, but he was at the Massachusetts Institute of Technology, MIT, which is in Cambridge, Massachusetts, right next to Boston. One of the best universities in the world. A highly technical university, a lot of major developments like computer language, the transistor, etc., were all first studied and developed at MIT. So he was working, Geisler was working with a colleague, Walter Rosenblith, who had a computer. In 1958, he developed a very, very primitive, by our standards, computer. And he could use that computer to signal average brain activity during auditory stimulation in human beings. And what he found was that there was a response arising from the auditory cortex. Well, at that point, he knew it was arising from the brain. He didn't know quite where. And it was not a muscle response. It was a real neurogenic brain response. And here's what it looks like. The top waveform shows a negative peak around 15 to 18 milliseconds. That's the NA, N meaning negative, A being the first wave. PA, it comes in around 25 milliseconds, never earlier than 22. And then if you set up your equipment properly, you'll also record a PB response out around 50 milliseconds. Now the amplitude of the middle latency is twice as big as the amplitude of the ABR. It's about 1 microvolt. Whereas the wave 5 of the ABR, even the best ABR you'll record is only about a half a microvolt, half of a millionth of a volt. Now there is one problem that you sometimes encounter in recording the middle latency, and that is the post-auricular muscle artifact. Now everybody's got a post-auricular muscle, and it usually contracts for very high intensity sounds, particularly when somebody's tense or their neck is a little tense. But we can usually get around that. One way to get around it is keep the electrode away from the mastoid. I never use a mastoid inverting electrode because you're just asking for trouble. You're putting the electrode right where the muscle is. So we can put the electrode on the nape of the neck or on the earlobe to avoid the post-auricular, and we can of course not avoid very, very high intensity levels in people who have relatively normal hearing. The yellow arrow identifies a classic example of post-auricular muscle artifact, and this is in a head-injured patient that I evaluated many years ago. This response is much higher in amplitude and sharper in peaks and much earlier in latency than the traditional middle latency. So that's how you distinguish it. Early latency, very, very high amplitude, abnormally high, and sharp peaks. It's more like a spike than it is a wave. Where does the middle latency come from? That research goes back to the early 1980s. Here's one study where the neurophysiologist put a grid of electrodes on the surface, on the dura of the brain of a patient undergoing surgery, neurosurgery, for treatment of epilepsy. And I've actually done this myself in the clinic, or not in the clinic, but in the operating room. And basically what they found was that the electrode, number 7 in this case, right over Heschel's gyrus, right over primary auditory cortex, produced the middle latency. None of the electrodes did. We now know that that is the case. Many studies with MRI, functional MRI, and other techniques, CT scans, have shown that patients with abnormal auditory systems, with lesions or damage in the primary auditory cortex, do not have a PA component. And there's pretty good evidence that the NA component, the first negative component, arises from the thalamus. Then there are radiation fibers that lead from the thalamus to the primary auditory cortex, which of course also are involved in middle latency. I want to thank Frank Music, who you'll be hearing from at the ISHACON 2019, um, who has given me his brain, or a picture of his brain, and I encourage you when you see him at the convention to actually come up, and he's probably knows more about neuro anatomy from an audiology point of view than anyone in the world. Protocol, very quickly, you take your ABR system and you modify it. There's no such thing as an AMLR system. You take an ABR system and modify it. You use tone burst now instead of clicks, or you could use speech stimuli. Use longer durations, slower rates, much slower rates. Sometimes I'll use a rate of 2 or 3 per second for the middle latency. Um, Polarity doesn't make any difference. Intensity, you want to stay away from the high intensities because that's where you're more likely to record post-auricular muscle artifact. Less amplification is needed because it's a bigger response. We need an analysis time of at least 100 milliseconds to see the PA and the PB. The filter settings they're very important. You must keep the low frequencies. You can't filter out the low frequencies because the energy, the most of the energy for the mid latency is around 40 hertz. So if you were to do a spectral analysis of mid latency, you'd see the energies at 40 hertz. But you don't have to do that. You can figure that out. Each of the major positive peaks is 25 milliseconds apart. So if something is 25 milliseconds apart and it keeps happening over and over, it's happening 40 times a second. So we know there's energy at 40 hertz. So a lot of times if you're just recording a middle latency, you can filter from about 10 hertz up to 250 hertz, and that'll give you a good response. Electrodes, we have to put electrodes over each hemisphere. That's one of the unique features about middle latency. We're trying to record a response from primary auditory cortex on the right and the left. And that's why I like the middle latency for any neuroaudiologic assessment when I need to use evoked responses, because I can get hemisphere specific information on primary auditory cortex. That's a vital part of the auditory system. You're not going to process speech properly. You're not going to have normal auditory processing unless primary auditory cortex is functioning normally. Now, I've done some research with colleagues with PhD students over the years showing that if you modify the middle latency protocol, slowing the rate very slow, less than 1 stimulus per second, and you make sure you pass through all the low frequencies. So you set your high pass filter setting for 1 hertz, and if you use a low frequency stimulus like 500 hertz, you actually can consistently record the PB component, which is arising from secondary auditory cortex. So this is even getting beyond the primary cortex, and it's even a more sensitive measure of auditory processing. You got to plug the electrodes in, of course, and each hemisphere electrode is non-inverting. But what do you do about the inverting electrodes? Well, there are two strategies, or actually three. I use a linked earlobe, so I've got an earlobe electrode, not a mastoid. Avoid the post-auricular area. A linked earlobe approach takes a little cable that connects the two inverting inputs, and then I put the electrodes from each earlobe into that cable, so I'm linking the earlobes. Another option, actually it's a better option, is to use a non-cephalic. That way you're away from the post-auricular muscle altogether. And that would be one electrode, one inverting electrode on the back of the neck, the nape of the neck, down near the shoulder. Some people actually use a system where if they're stimulating the right ear, then they'll use a right earlobe electrode, and if they're doing the left ear, the left earlobe electrode for inverting. So it doesn't make much difference because none of the response is coming from the ears. In the interest of time, I won't read this slide, but let me tell you there are many factors that influence the middle latency, and that kind of gives some people some pause in whether they should even record it. But don't be discouraged. It does mature over time. It doesn't fully mature until age 10. So the only factor, the only way age is a factor is you need to slow the rate down for younger children. But you can record in middle latency from newborn infants. Sleep is a big factor, post-auricular I mentioned, and of course you can't use sedation or anesthesia. You can't suppress the cortex and then record a cortical response. Frank Music, as I've mentioned, has done a tremendous amount of work on this. He's published many papers. This is just one of many. And I encourage you to read his work, talk to him, read his books. He's actually got normative data, he and his colleagues, many of whom are former students or fellows that have worked with him, normative data that you can use, and you can follow his protocol to record a middle latency and use his normative data to analyze it. I'm going to move on quickly now to the late response. The late response was actually the second of all the evoked responses to be discovered. This was back in 1939. You'll recall that the ECOG was discovered in 1930. Hallowell Davis was one of the researchers who discovered the late response, and of course he's the father of auditory evoked responses. He's been involved in ABR research, middle latency research, of course late response research. He actually wrote the textbook that I used for my introduction to audiology program. So course, he's was a remarkable man. Now we're talking about a very high level response. The late response comes from probably primary and secondary regions of the auditory cortex, but also others, the frontal lobe, and other parts of the brain that aren't directly related to hearing. So we don't know exactly where a problem is when the person has an abnormal late response, but we do know they have a cortical auditory problem. And one advantage of the late response is we can use speech stimuli to evaluate it. So we're not trying to find a lesion here. We're not trying to find a disorder. We're trying to use an evoked response to get objective information on whether the auditory system is functioning properly, and in infants, whether it's maturing as it should with auditory stimulation. This is actually a rather easy response to record. You can record it with an ABR system, and it's large. The typical amplitude will be 5 to 10 microvolts, so it's quite easy to detect. These are the main components. P1 of the late response is really the PB response for the middle latency. It comes in at 50 milliseconds. And for a lot of the infant studies, that's what we're actually recording. There's a great maturation of the late response over the first 12 years. So when you have an infant or a very young child, you're not even recording the P2. That's has not yet evolved. You're recording the P1 at a latency which is around 100 milliseconds. As you get into older children, like school-age children and older patients, like adults, then you'll start to record what you see here. An N1 around 100 milliseconds, and P2 around 200 milliseconds, and sometimes an N2 around 200 milliseconds. The analysis is mostly latency and amplitude, quite easy to set your cursors up, and you can either record amplitude from a consistent baseline, which we usually use a pre-stimulus baseline for that, or you can record amplitude from the N1 to P2, but now you're recording the amplitude for two waves in combination. So it's better to use a baseline and go down to N1 and up to P2. Parameters are quite different For the late responses, now we definitely need to use either tones or speech signals. Many people use speech signals, such as da or ga, and that way you're getting a response that's more closely related to behavioral auditory processing. Very long duration. These neurons in the cortex need a lot of time to, to fire adequately, and a very slow rate. The slower the rate, the bigger the response. So at least a rate of one stimulus every 2 seconds. If you use even a slower rate, that's even better. Of course, the slower the rate, the longer it takes to get the response. Polarity is not important, and we avoid very high intensities. Here's an example of stimulus duration. The longer the duration of the stimulus, the lower the threshold of the ALR. So it's always good to use a long duration stimulus for the cortical response. Here's an illustration of how slowing the rate down actually gives you a bigger response. So a rate of one stimulus every 2 seconds, or an interstimulus interval of 2 seconds, would be a rate of 0.5 per second. That is, you can't really present half a stimulus per second, so that really means one stimulus every 2 seconds. If you wanted to go even slower, then the amplitude would be much bigger. The problem then is it's going to take you longer, and the patient may not remain in a calm state. Going on to the acquisition parameters for the late response, a longer analysis time. We can now use a midline electrode. We don't use hemisphere electrodes clinically for measuring the middle latency. Could be on the vertex, or it could be on the high forehead. And we use filter settings where all the low frequencies are preserved, because this is a very low frequency response. This response, the energy is mostly around 10 hertz. Now, what a lot of people are using these days to record the late response is a electrode cap, as you see here. So once the person's prepared with a shampoo that basically is a conducting gel, you put the cap on and all the electrodes are in the right place. And you don't have to be putting on multiple electrodes. But you don't have to have this many electrodes. You can get by with one non-inverting and one inverting, or linked earlobes, or nape of the neck. You can see the nape of the neck at the back of the figure at the top. And then it's very important to put an electrode near the eye so that you can rule out eye blink muscle potentials and not mistake them for the late response. A lot of factors, of course, influence all responses. This response matures much slower, whereas the ABRs mature by 18 months. This response is not mature until up to 12 years, and it may deteriorate as a person ages. Obviously, sleep's a big factor. You don't want the patient sleeping. Many clinical applications for the late response. We can use it diagnosing auditory processing disorders in any age, children or adults. It's very useful in diagnosis of auditory neuropathy, believe it or not, even though that lesion is, or disorder is, down near the cochlea and the auditory nerve. Because we're using a long duration stimulus, many milliseconds, we don't have the problems that are associated with a desynchrony abnormality, ANSD, where the neurons can't fire to very rapid stimuli. These stimuli are not so rapid. One of the biggest applications most recently is documenting, by measuring the late response, that hearing aids are helping, or if the hearing aids aren't helping, that a cochlear implant is helping. And that's because this response is a measure of cortical maturity, auditory system maturity. And if the hearing aid is working and the brain is getting adequate stimulation, then of course we should see a maturation of the response. And there are dozens of articles documenting this application of the late response. Here's just an example of some work done by Anu Sharma. Many of you are familiar with her name. She's certainly visited India before, showing that you can record a really good late response using sounds produced by a little loudspeaker and going through a hearing aid or going through the processor of a cochlear implant and get a perfectly normal response. Now what she marks as P1 is actually the PB component of the middle latency. At least that's what most people think. And as the child matures, you begin to see a P2 as well. I'm going to wrap up the responses in a moment here with the P300. It was co-discovered back in the mid-60s by these two people, Hallowell Davis and Samuel Sutton. It's recorded like you'd record a late response, except you don't have just the frequent stimuli that you do for the late response. About 20% of the time, and randomly, there's an infrequent, unexpected, unpredictable stimuli. If the person's paying attention to that stimuli, you get a big response at 300 hertz. If the person's not paying attention to the rare stimulus, then you'll get a smaller wave a little earlier than 300 hertz. Once you set up the equipment for a late response, you pretty much can record a P300, except you have to have a special option that will allow you to present both frequent and rare stimuli, and to control the percentage or probability of the rare stimulus, keep it around 20%, and you need to make sure that you can record a separate waveform for each of those stimuli. So not all pieces of equipment actually have a P300 option. Okay, two more slides with data on them. We're now going to pull it all together. The point I've been making is if we use a test battery of objective tests, neurophysiological procedures, as we've discussed, you can evaluate pretty much the entire auditory system. So as shown in this slide, the plus marks indicate how useful or how sensitive the procedure is to a disorder in that area. So 3 pluses for the middle ear means that's a really, really sensitive measure of middle ear function. And the negative or minus sign means there's no value whatsoever in using this response to evaluate that part of the auditory system. So you can see from the pattern that some responses are really good for measuring higher level auditory function, others for lower level, and if we use the right combination of procedures, we can accurately diagnose hearing loss anywhere in the auditory system, even without behavioral techniques. This is a similar figure, similar table, but now we're looking at clinical applications. So on the left you see applications, newborn screening, preschool screening, all the way up to documenting the outcome of management with cochlear implants, hearing aids, auditory training, etc. Same concept. We use different responses for different purposes, and we often combine them. So we may use oral emittance measurements, tympanometry and reflexes, and OAEs and ABR in some patients. And other patients, we may not even need to worry about OAEs. We may need to focus more rather, on the cortical responses. So it really depends on what we are using these responses for. All right, we've come to the end of our 3 hours. I wish I had been there to give the lecture, but in any event, I hope you found it useful. You certainly should have access to this PowerPoint presentation, but if you need it, if you don't have it, just contact me, and do check out my website. There's plenty of valuable information there. And then in conclusion, I've just included the last 2 books I've written. Of course, I'll be putting an ABR book together sometime in 2019, but I encourage you to check these out. Thank you very much.